now. So my name is Bahami. I'm the social media manager for Leicester Radiology Society, and I'll be talking about lower limb, and Adit will be talking about thoracic and lumbar spine, and we also have today with us Dr. Neil Raja, who is a consultant radiologist, and he has reviewed this presentation. They'll introduce themselves now.
Hi everyone, I'm Adit, and I'll be doing the spinal section of the PowerPoint.
Hi, my name's Neil. I'm one of the consultant MSK radiologists at UoL, and I reviewed the excellent presentation by Dahami and Adit. So I look forward to an engaging talk.
Okay. Today, I'm going to go through some quick how to interpret MSK imaging, and then we're going to go through some cases of different presentations. There'll be some references and a little summary at the end. Okay. So to start off with, how do we interpret a musculoskeletal X-ray? So the number one thing that we always have to do and never to forget is to confirm patient details. So you need to check their patient name, date of birth, and NHS number. Then what we need to do is we need to look into the film details. So the date and time the film was taken and what area of the body was scanned. Then we can go into adequacy of the film. Usually you would require about minimum 2 projections, and ideally you should have the joints above and below also imaged, and you would also look into rotation and penetration. And it's always helpful to have any can you guys see the new slide? Okay, just to confirm, can you see the slide that I'm on right now? So it's on how to interpret a musculoskeletal X-ray. Okay, perfect. Okay, and yeah, so it's always useful to have a previous image of the same thing, so you would always check that. And lastly, you would go through your ABCS criteria, and we'll get onto that now. So ABCS is, so it stands for A for alignment and joint space, B is for bone texture, C is for cortices, and S for soft tissues. Okay, so to help you guys orientate, so we have the left femur here and the left hip joint. If you look at the image on the right, you can see in green the normal Shenton line. So this is a line that shows disruption when we have a
Dahami, I think I'll have to do it for you. Just
okay.
Yeah.
Can you guys see the slides now?
We can see the correct slides now.
Sorry about that. Yeah, so you can see the green line, so that's the normal Shenton line. So that's the line that can show disruption when we have a neck of femur fracture with dislocation. And what that means is that when we have a neck of femur fracture, then that can show like different orthopedic management that is prompted there. And on the left, you can see the different lines showing the different types of fractures that can occur and the names for each of those fractures. Broadly, we can classify them into intracapsular and extracapsular fractures. And the reason why this has a clinical significance is that when we have fractures in these different areas of the neck, it can prompt different orthopedic management, and it's important to be aware of these. It's also important to know the type of vascular and soft tissue surrounding it as well. We can move on to the next slide, please. So we have the difference between extracapsular and intracapsular fractures. Essentially, intracapsular fractures are fractures that occur proximal to the intertrochanteric line, and this is clinically significant because this can impede blood supply from the FCA and the nutrient arteries, so they have a higher risk of avascular necrosis, whereas the extracapsular fractures occur below the intertrochanteric line, and they have generally better prognosis because the blood supply is usually preserved. Okay, and then now we can move on to our first case. So case 1 is of a 28-year-old male brought into the emergency department after a high-speed motor vehicle collision. He was the unrestrained driver. On arrival, his right lower limb is flexed, adducted, and internally rotated. He complains of severe hip pain and inability to move the leg. Distal pulses are present, but he reports numbness along the dorsum of his foot. So heart rate 118 BPM, BP is 108/72, rest rate 22 breaths per minute, and oxygen is 97% on room air. Temp is 36.8, and GCS is 15. So if you could write on the chat what investigations you would like to do. Yeah, thank you, Amna. So you would do an X-ray, anything else? CT for body trauma, okay. Okay, should we move on to the next slide, please? FBC, UNEs, LFTs. Yeah, those are very important. Okay, so investigations that we would normally do here are, you would do initial A2E assessment. You would do an FBC, like Ishan said, to assess blood loss. And you can do UNE, UNEs for a baseline renal function to guide any sort of analgesia or IV fluids that they might be given. Yeah, maybe X-ray of the hip and trauma lateral. Yeah, these are all very reasonable. And CT with bony reconstruction. Yeah. Okay, let me get that. Yeah, and then it's very important to do a group and save and cross match to prepare for any potential surgery for any patient with fractures. Yeah, and then you would also do an X-ray as well. We can move on to the next slide, please. And chest X-ray, yeah. Sorry, just give me a second. My slides are acting up. Okay, so what is the main finding on this X-ray? So this X-ray shows a posterior dislocation of the right femoral head in relation to the acetabulum. There is widened joint space on the affected side. If you guys could name 2 important nerves that might be at risk in this injury and maybe describe one clinical finding for each nerve. Sciatic and superior gluteal, yeah. We can move to the next slide, please. Yeah, so the 2 main ones are sciatic nerve and superior gluteal. So the clinical findings would be, with sciatic nerve, it will be sensory loss over dorsum of foot or weak dorsiflexion or foot drop. And with superior gluteal nerve, you would get weak hip abduction, and you would also get Trendelenburg sign. So what would be your initial management for this patient? Reduction, okay. Thank you, Aksha. Anything else? Okay, if we can move on to the next slide, check X-ray and send. Yeah, that sounds good as well. Neuromuscular exam. Okay. Yeah, so the first thing you would do is ATLS, and then you would make sure that they're given enough analgesia. You could do a neurovascular assessment of the limbs, and you could do a close reduction within 12 hours, or you can operate on them and do an open reduction. Okay. If you can identify 3 complications associated with this condition. So any 3 complications that might be associated with this. Post-traumatic arthritis, yeah, for sure. Okay, should we move on to the next slide? Okay, main thing is avascular necrosis of the femoral head. And like you said, yeah, post-traumatic arthritis, vascular necrosis, yeah, and sciatic nerve injury as well. Okay, and then we move on to case 2 now. So case 2 is of a 79-year-old woman who is brought into the emergency department after tripping on a rug at home. She reports immediate left hip pain and is unable to stand. She has a history of hypertension, osteoporosis, and mild cognitive impairment. She takes amlodipine and alternate. On examination, she is lying on the trolley with left leg shortened and externally rotated. Neurovascular exam is normal, and you can see the vital signs there. What initial investigations would you guys do? Pelvis and hip x-ray, NOF, yeah? Sounds very reasonable. FBC, LFTs, kidney function tests, yeah? Yeah, I think that's all good. So let's look at the answers. Yeah, so you would do an x-ray pelvis and hip, AP and lateral views. Then you would do a neurovascular exam and FBC unis. Again, group and save and cross match just in case they need surgery. And you would do a bone profile because it's a elderly woman, postmenopausal. Okay, so what is the main finding that you can see on this x-ray? Trauma HPX may not look quite optimistic. Yeah. Is there a dislocation? Yeah, there is a dislocation. Okay, let's look at the answers. So it's intracapsular fracture. Yeah, so it's a displaced subcapital fracture of the left femoral neck. You can see like a line going through the femoral neck, and you can see the head has displaced from the neck. And the Shenton line that I was talking about earlier, you can see that there is a disruption to that. Okay, and what classification system is used to grade femoral neck fractures? Garden, yeah, thank you. So next slide. Okay, so this is a looks very wordy, but it's just the garden classification. So you can see first is like undisplaced incomplete, second is undisplaced complete, and then 3 is complete fracture incompletely displaced. And you can see the other 2 as well. I think this classification is quite important to know as well. Okay, so what factors in her history increases the likelihood of a hip fracture? Old age, yeah. History of osteoporosis, yeah. Female, yeah. I think female of like a elderly age, yeah. Yeah, okay. And then let's look at the answers. So yeah, like you guys said, old age, 79 years old. So she probably has reduced bone density and also at an increased risk of falls. She also has osteoporosis, which increases chances of her getting a fragility fracture. Female sex, yeah, post-menopausal bone loss increases fracture risk, and history of falls, mild cognitive impairment as well. These all increased risk of falls and fractures, and possibly she might be very fragile or living alone as well. So what management would you consider in this case? Fixation. Yeah. Can you be more specific? So how would you sort of like manage this patient if you saw her in any hemiarthroplasty, lip placement, surgical intervention? Yeah. Okay, so let's look at the answers. So so before operation, you could do sort of like analgesia, give her enough painkillers, do fluid resuscitation, correct electrolytes, or any dehydration issues. Surgery-wise, you can do a hemiarthroplasty for displaced intracapsular nerve fracture because it has a high risk of avascular necrosis. Post-op, it's important to do early mobilization with physio and also give VTE prophylaxis after surgery. Okay. And the next slide is just some couple of x-rays of different types of knot fractures. It's just, although it's just good to include that, it's probably good to just kind of like have an idea of what each type looks like on an x-ray. Okay, and next is case 3. So case 3 is of a 28-year-old male recreational athlete presents to emergency department after sustaining a knee injury while playing soccer. He reports that he had jumped for a header and landed funny. So you can see the vitals on arrival. So his temperature is 37, heart rate 96, BP 122/76, breast rate 17, and oxygen 99% on room air. On examination, there is swelling around the right knee with localized tenderness over the lateral tibial plateau. Range of motion is limited due to pain. No open wounds are present. Distal pulses are intact. Sensation over the dorsum of the foot is normal. What initial investigations would you carry out? X-ray, knee X-ray, AP, and HBL, or dislocation possible for tib fib? Yeah, these are good ideas. Let's look at the answers. Okay. So investigations-wise, we can do FBC UNEs, again, group and save and cross-match. You might want to look into CRP and ESR for any inflammation, and do an AP and lateral X-ray of the tibia and fibula. Again, you must do a neurovascular examination as well. So this is the X-ray that was taken. What can you see on this X-ray, if anyone can see any pathology? Can everyone see the X-ray? Lateral tibial plateau fracture. Yeah, perfect. Okay, let's move on. Yeah, it is type 1 tibial plateau fracture. It's you can see the arrow pointing towards it is just a split through the lateral plateau, and there is no like depressions or comminutions. Okay, so what is the classification for tibial plateau fractures? Okay, should we look at the answer? Okay. Yeah, Schatzner. So Schatzner classification is what we use for tibial plateau fractures. It looks like quite a lot, but there is Dr. Raja told me that there is a breakup analogy that you can use to remember it. It might be too long for me to explain it here, but I think it's a very good way of remembering it. So I'll let you kind of do that on your own time. What important structures are at risk in a tibial plateau fracture? Okay, should we look at the answers? Okay, so the main important structures are lateral and medial meniscus, the cruciate ligaments, and the neurovascular structures like the common peroneal nerve and the popliteal artery. Yeah, and I think we go on to case 4 now. So case 4 is a 40-year-old male who slips on a wet floor and twists his right ankle while landing on the lateral side of his foot. He presents to the emergency department with severe pain, swelling, and inability to bear weight on the right leg. Vital signs are 36, temperature, heart rate is 98, blood pressure is 180/78, 120/78, respiratory rate is 18, oxygen is 98% on room. On examination, there's swelling and ecchymosis around the medial and lateral malleoli. Tenderness over both malleoli and deformity noted medially. Skin is intact and there are no open wounds, and you can palpate the distal pulses. Normal cap refill. Neurovascular exam is normal as well. Okay, what can you see on the X-ray? Both tibia and fibula fractured. Yeah. Okay, and let's see the next slide. So yeah, like Amna said, it's a fracture line through distal tibia, which is the medial malleolus, and the distal fibula, which is the lateral malleolus. So it's a bimalleolar fracture. What classification systems do you guys know that is used in ankle fractures? Okay, should we look at the answers? Weber, yeah, thank you. Okay, so Weber's classification is the commonly used one. So you have 3 types: type A, type B, type C. I think this image does a quite good job at explaining it. Type A is where the fracture line is below the syndesmosis, and that's usually a very stable fracture because it actually doesn't really it hasn't disrupted any of the ligaments of the ankle joint. And you can usually manage that non-operatively. Type B is at the level of the syndesmosis, so it might be stable, might not be, really depends. And type C is when the fibular fracture is above the syndesmosis. That means that the ligaments are disrupted, making the ankle very unstable, and it usually requires surgical fixation. Okay, and what neurovascular structures should be assessed in ankle fractures? Tibial artery, posterior tibial artery, dorsalis pedis artery, tibial nerve, etc. Yeah, should we look at the answers? Okay, so we should be looking at the nerves, so especially the superficial peroneal nerve, which gives sensation over the dorsum of the foot, the deep peroneal nerve, which gives sensation between the first and the second toes, and also helps dorsiflex the toes. Tibial nerve, which is sensation on the sole, and plantar flexes the toes, and sural nerve, which is the lateral aspect of the foot and the ankle. And in terms of the vessels, you can look at the posterior tibial artery, and you can palpate that posterior to the medial malleolus, and you can try and palpate the dorsalis pedis artery or the dorsum of the foot, and then also you should try and see if the capillary fill is normal. I think that is the last case for me. Adit will take over from now. Thank you.
Hi guys. So can you all hear me? Yeah, brilliant. So I'm going to move on to the next part of the session. So this is going to be on the spine, so specifically the thoracic and lumbar spine. So before we get into any cases, I just want to go through some basic anatomy and some spinal imaging. So just firstly, so spinal X-rays. So as with any other X-rays, we want to go through the basics. So we want to know what type of view. So we can have AP views and then lateral views on X-ray. Then you want to have a look at alignment. So this is specifically refers to a lateral X-ray. So when looking at the alignment, you want to have a look at three imaginary lines. So one of those is the anterior vertebral line, and that follows the anterior parts of the vertebral bodies. Then you have the posterior vertebral line, which follows the posterior parts of the vertebral bodies, and then you have the spinolaminar line, which lies just posterior to the spinal canal. So then you'd want to look at the vertebral bodies themselves, and the ones above and below the vertebral body you're looking at should roughly be uniform and equal. The vertebral body should be rectangular in shape as well. Then you want to have a look at the intervertebral discs, which are these, and they should have roughly the same spacing between each one. You want to have a look if there's any sort of narrowing of the intervertebral disc space. And then people often forget this, but you want to have a look at the posterior part of the spine, so the spinous processes and the pedicles. And then you want to have a look at everything else. So you want to have a look at the sort of like bone density and stuff like that. So if we just quickly go through these annotations, so this is the rib here. Then you have the vertebral body itself. So this is a joint, so it's the costovertebral joint here. And then this is pointing to this, which is the spinous process. You then have this annotation here, which is pointing to the transverse process. And then between the transverse process and the rib is the costotransverse joint. You then have the intervertebral disc space and the intervertebral disc within it. And then you have this, which is pointed to the pedicle. And then again, this is the intervertebral disc space. This is the vertebral body. This is the facet joint. It's quite hard to see. And then these are pointed to the articular processes. So this is the inferior part, and this is the superior part. And then, yeah, the inferior part and the superior part. And then number 12 is pointed to the intervertebral foramen. So next, I want to talk about spinal MRIs. So X-rays are good for looking at structural changes, and they're particularly useful when it comes to looking at fractures. But with MRIs, it's useful for looking at soft tissue. And there's two main sequences that's associated with MRIs, and that's T1 and T2. And the difference between T1 and T2 is what appears bright. So on T1, only one tissue appears bright, so that is fat. However, on T2, only uh, uh, both tissues appear bright, both fat and water. So a key way to tell the difference between T1 and T2 is to have a look at the CSF. So on on a T2 weighted image, the CSF will appear bright. However, on a T1 weighted image, the CSF, which is here, is going to appear dark. So that's a key way to be able to tell the difference. So I just want to briefly talk about STIR. So STIR is a specialized MRI sequence that's really useful when it comes to spinal imaging. And it's based on it's based on a T2 weighted image. And what STIR does is it suppresses fat signals. And as we said from the previous slide, on a T2 weighted image, two tissues are bright, both fat and water-based tissues. What STIR aims to do is it suppresses fat signals. So that results in a STIR image only showing water-based tissues as bright. And it's really useful when you're wanting to detect any inflammation, edema, and pathology near fat. So if you can see in this image, on the left side, you can see a T1 weighted image, and then on the right side is a STIR image, and it's of the same area. On the T1 weighted image, you can see these areas of dark signals on the vertebral body, and dark on the T1 image suggests this fluid. However, on a STIR image, you can see it appears brighter and with more clarity. And on a STIR image, anything that's bright is fluid. And you can see the benefit of a STIR image through this. And this pattern suggests spondylodiscitis. So uh, I'm going to start with the cases now. So the first case is a 35-year-old mom presenting with a 3-day history of severe lower back pain radiating down both legs, who reports new difficulty passing urine, numbness around the groin, and progressive weakness in both legs. On examination, he has reduced anal tone, bilateral lower limb weakness, and decreased perianal sensation. So if you can there's two questions, if you can write in the chat as before. So what from this history are the red flags that you can spot? And what is the single most important investigation that you'd do? Yeah, so yeah, the man has difficulty urinating, retention, and reduced anal tone. And yeah, urinary retention, and then MRI of the spine. Yeah. So if we go through yeah, MRI potential, no impingement. So if we go through the answers, so the key red flags that the patient was presenting with, he had bilateral sciatica, he was experiencing saddle anesthesia, he said that he had difficulty passing urine, so urinary retention, and had bilateral motor weakness of the legs, and these are all key features that are suggestive of Cauda-Equina syndrome. So, in terms of the investigations, the number one first line investigation that you want to do is an emergency MRI because Cauda-Equina is an emergency presentation, and you want to do an emergency MRI of the lumbar spine to be able to confirm or exclude it. And in terms of supportive investigations, you'd want to do a bladder scan to check for you may want to do a bladder scan to check for urinary retention. You'd want to do a full neurological exam and a PR exam as well. And in terms of bloods, you'd want to do a full blood count, your infective markers, so CRP and ESR, and using these. And if your suspecting infection, you'd probably want to do blood cultures as well. So the next question. So I've got two MRIs from this patient. So what abnormalities can you see on this MRI? And what do you think the cause of this patient's cauda equina is? Let's give you a few seconds. Yeah, so lateral disc extrusion at the level L4, L5. Yeah, L4, yeah. Widen off the disc, yeah. So I'll just go through it. So we want to establish what type of sequence are we looking at. So as I said before, look at the CSF. So the CSF is bright, so we're looking at T2 weighted images here. So if we start with the vertebral bodies, these all seem uniform and there's no abnormal signals coming from these. Then looking at the vertebral discs, the intervertebral discs, you can see that when it comes to the L4, L5, it appears darker and you can see that there's some sort of dark signal coming here, and that's a disc extrusion at the level of L4, L5 that's occurring. You can also see at the L5, S1 junction that the disc appears dark here, and this is disc desiccation, which is where the disc has lost its hydration and is suggestive of disc degeneration occurring. And then looking at the CSF, on a normal MRI, this should be smooth and continuous. However, when it comes to the L4, L5 junction, you can see there's effacement of the CSF, which is suggested that the spinal canal narrowing and that there's compression of the cauda equina. So the cause of this patient's cauda equina is the disc extrusion at L4, L5 level. Looking at the axial view of this patient's MRI, so it can be very difficult to interpret. So if we just go through some basic anatomy, so this is a vertebral body, so this is the vertebral body here. You have the facet joints here, and then you have the canal, which contains the CSF. So this is a T2 weighted image, so it should appear bright as it does on here. However, you can see that it's dark, it's got a dark signal, and that suggests that the spinal canal narrowing and the CSF can't pass through. So on to the next questions then. So do you know any other causes of compression that may lead to cauda equina? And do you know what the difference is between radiculopathy and cauda equina syndrome? If you just answer in the chat. Yeah, trauma, a fracture and cancer, yeah. Cysts and tumor, and then disc prolapse and tumors, yeah. Yep, these are all correct, yeah. So I'll just go through the answers then. So the causes of compression, so as with just with this case, like disc prolapse, is a a key cause of compression that leads to cauda equina, and particularly at the L4, L5 junction or L5, S1 junction. You can also have tumors, particularly metastatic tumors of the spine, that can cause compression, trauma resulting in fractures. You can have epidural collections, as we said, like blood and pus, and then spondylolisthesis, which is basically anterior displacement of the vertebra from the vertebra below. So in terms of the difference between radiculopathy and cauda equina, so radiculopathy is when one nerve root is compressed, So it usually results in unilateral symptoms, and it occurs in a dermatomal pattern. The key difference is you don't get the bowel or bladder issues, and it's usually caused by small disc bulge or foraminal stenosis. However, with cauda equina, you can see that the cauda equina, its natural anatomy, it distributes and it spreads out like a horse's tail, and so this means that multiple roots are susceptible to compression, so between L2 and S5, and it leads to bilateral sciatica and weakness. And you also get sudden anesthesia, urinary retention, and bowel dysfunction, and reduced anal tone. So the next question, what would the immediate management be for this patient? If you can just put in the chat. Yeah, emergency decompression. Yeah, that's correct. So you'd want to do emergency surgical decompression. So that involves laminectomy and discectomy. So this ideally should be done within 24 to 48 hours to reduce long-term complications. So on to the next case. So a 55-year-old man presents with a 5-year history of chronic lower back pain and stiffness. He reports the pain and stiffness is worse in the morning, lasting about an hour, and improves with movement. He has recently found it increasingly difficult to bend forward when trying to tie his shoelace, and the discomfort has been disturbing his sleep. He denies any trauma, fever, weight loss, or neurological symptoms. On examination, he has a mildly stooped posture, reduced lumbar flexion, and tenderness over the sacroiliac joints. So the first question, what features in this history suggest inflammatory back pain rather than mechanical back pain? Just give you a few seconds. Yeah, age over 40. It's chronic arthritis fragility fracture pathology fracture. Okay. Morning stiffness lasting more than 30 minutes. Okay, let's go through the answers. So he's experiencing pain and stiffness that's worse within the morning, and it lasts about an hour, and it improves with movement. And he's experiencing night pain as well. And these are all features that point towards inflammatory back pain. So if we just go through this table, so inflammatory back pain tends to occur below the age of 40, and its onset tends to be gradual. If morning stiffness is present, it tends to last over 30 minutes, and the pain and stiffness improves with exercise, and you tend to get night pain with inflammatory back pain, and it's worse at rest. However, with mechanical back pain, it can occur at any age, but it tends to occur over the age of 40. You get, if morning stiffness is present, it typically lasts under 30 minutes. The pain tends to improve with rest. You don't usually get night pain, and the pain worsens with activity. So, based on the patient's presentation, what broad differentials should you consider?
Adelante. అంటే
పాయసం తిన్నప్పుడు
తిను నీకు ఇష్టంగా.
I think someone's unmuted. Okay, I'll just go through the answer. So you should consider, so because the history is pointing towards inflammatory back pain, the top differential should be ankylosing spondylitis, and that's because of the reduced lumbar flexion the patient's experiencing. And he's also got tenderness over the sacroiliac joints, which are key features of ankylosing spondylitis. But you should also consider psoriatic arthritis and reactive arthritis. You shouldn't rule out mechanical causes as well. So you should also consider degenerative disc disease, osteoarthritis, muscle strain, compression fractures, and spinal stenosis. So, what investigations would you request initially? Just give you a few seconds. CRP, ESR, FBC, yeah, those are all correct. Use the knees and LFTs, yeah. So if I just go through it, plain film, L-spine, X-rays, yeah, okay. So if I just go through the answer, so in terms of blood, you'd want to do your inflammatory markers, so CRP and ESR, and you'd want to monitor these regularly with ongoing disease. You'd also want to do HLA-B27 genetic testing, and you'd want to do full blood count using these and LFTs. In terms of imaging, for ankylosing spondylitis, the first line imaging test is MRI of the sacroiliac joints. And it's an MRI because it shows active inflammation early on disease, whereas with X-ray, you can see structural changes, but these only tend to occur later on in the disease and once the disease has established. So the next question, so what early abnormalities, does anyone know what early abnormalities can be seen on an MRI in ankylosing spondylitis? Just give you a few seconds. Yeah, bone marrow edema, yeah, that's correct. Yeah, I'll just go through the answer then. So the two key main features that can be seen on an MRI in ankylosing spondylitis is bone marrow edema and bilateral sacroiliitis. So if we go through these MRIs, I know it is a little bit small. So this is 4 images of the same patient. And these are stir images. So on stir, only fluid is bright. And these are lateral views. And then this is also a stir image, and this is an axial view. And this is a T1 image, an axial view as well. So key sign is bone marrow edema, and it's a little bit difficult to see, but if you can see in the corners of the vertebra, there's little bright spots that are present, and this is representative of bone marrow edema, which suggests there's active inflammation ongoing. And then on the axial X-ray, these are the sacroiliac joints. We can see there's bright areas around the sacroiliac joints here, and this does suggest, and it's bilateral on both sides, and this is suggestive of sacroiliitis, so bilateral sacroiliitis. And these are the two key main changes that you can see on someone with ankylosing spondylitis on an MRI. So the next question. So I've given the patient X-ray. So what abnormalities can you see on this patient's X-ray? Yeah, bamboo spine. That's correct. Yeah. Yeah, very narrow joint space. Yeah, that's correct. So if I just go through the answers then. So so firstly, this is an AP view of the AP X-ray. And um, if you can see, so on a normal X-ray, you can see that there should be um, uh, spaces between the um, vertebra, which is where the intervertebral discs are, and there's loss of the intervertebral disc space. And this is because there's syndesmophytes that have formed, and these are bony spurs. They tend to occur at the corners of the vertebra, and these bony spurs have occurred due to chronic inflammation. And over time, this has narrowed the space between the vertebra. And as a result of that, it gives the effect of bamboo spine, um, which is a key sign on an X-ray of ankylosing spondylitis. You also have dagger sign as well, which is calcification of the interspinous ligament, which is shown here. And then you also have the iliatic joint as well, and there's loss of joint space here, and that's suggesting chronic sacroiliitis. So the next question. So what is the management of ankylosing spondylitis? Physio and NSAIDs, yeah, that's correct. So if I just go through the answer. So in terms of conservative management, so physiotherapy, exercise, and mobilization are key for those who suffer with ankylosing spondylitis. You'd also want to um, advise smoking cessation if the patient does smoke, and you'd want to consider bisphosphonates for osteoporosis, as those with ankylosing spondylitis are at risk of fractures as well. And you'd want to consider surgery if it's at a severe point. But the mainstay of management is medical management. So first line, you'd want to give NSAIDs. Second line, you'd want to try anti-TNF agents such as adalimumab and infliximab. And the third line is interleukin 17 inhibitors and JAK inhibitors as well. And you can consider targeted therapy using injectable steroids or steroid injections for specific joints as well. So on to the next case now. So a 75-year-old woman presents to the emergency department with sudden severe lower back pain after slipping on a wet floor in a bathroom. She denies any weakness, bladder or bowel symptoms, or radicular pain. She has a past medical history of COPD, of which she takes long-term corticosteroids. On examination, she has midline tenderness around the thoracolumbar junction, but her neurology is normal. So the first question is, based on this history, so what do you think is the most appropriate first-line imaging modality? Plain film X-ray, yeah, that's correct. Yeah, so first line is an X-ray of the thoracolumbar spine. You'd want to do AP and lateral views. Um, you may want to consider an MRI. However, in this patient, she's not experiencing any sort of um, any sort of neurological symptoms. So an MRI would be less indicated, but you may want to consider it as well. But it's helpful an MRI would be helpful to be able to differentiate between acute and chronic fractures and an osteoporotic versus a metastatic fracture. So the patient's X-ray has come back. What abnormalities can you identify on this X-ray? L1 wedge fracture. Yeah, that's correct. So if I just go through the answer, yeah, loss of vertebral height, yeah. So if we go through it systematically, so it's a lateral X-ray. So if we imagine our three lines, so the anterior vertebral line, which is the anterior part of the vertebral bodies, it should, on a normal X-ray, run continuous. However, you can see of this vertebral body, which is the L1 vertebral body, it lies slightly anterior, so it's not smooth and continuous. The posterior line is normal, and the spinal ligamental line is normal as well. So yeah, so it's the L1 vertebral body that's affected, and there is loss of the um, vertebral body height, specifically the anterior part, compared to the posterior part. And that leads to an angular deformity, which is known as a wedge fracture. And wedge fractures are um, um, are very suggestive and very common in patients who have osteoporosis and those who are elderly as well. You also have diffuse osteopenia as well. Look at the vertebral bodies. And then this is an incidental finding. So this is so it's calcified opacities, and these are likely gallstones. So I just want to briefly touch on the AO classification. So AO is a system that organizes thoracolumbar fractures by the mechanism and structural pattern. So it splits fractures into three main types, so A, B, and C, with the severity and instability generally increasing from A to C. And it's useful because it helps to link the force applied to the fracture pattern seen. So I think the table's slightly cut off here. But uh, so type A tends to be compression fractures. So it tends to involve one vertebral body only, and is usually caused by axial loading. And examples of compression fractures are wedge fractures and burst fractures. You then have type B, which is usually caused by tension and flexion distraction mechanism as well. So that's where the vertebrae are the posterior elements are pulled apart. And an example of this is a chance fracture, where there's a horizontal fracture that occurs in the posterior element um, of the spine. And then you have type C, which is translation. So this is where the spine is rotated and sheared, and it tends to involve the posterior elements of the spine, and it tends to be the most severe type of fracture. An example of translation fracture is a fracture dislocation. So I also want to just briefly talk about TLIX, which it stands for Thoracolumbar Injury Classification Severity Score. So TLIX is a scoring system that helps to guide treatment decisions for spinal fractures. So it's based on three categories. So morphology, the integrity of the posterior ligamentous complex, and the neurological status of the patient. So you don't need to know this in detail, it's just good to know about. Um, and you have the different categories within these as well, and each one scores differently. And a score of more than 5 indicates surgery is likely needed, and a score of less than 3 or equal to 3 um, indicates that conservative management may be the best option. So the next question. So what factors puts this patient at higher risk of fractures? So I'll just give a couple of seconds in the chat. Yeah, long-term steroid use, absolutely. Older age, smoking history as well. Yeah, that's correct. So if I just go through it. So for this patient specifically, she's 75, um, and she's postmenopausal. And these are key risk factors for osteoporosis, which puts her at risk of a fracture, a greater risk of a fracture. She also has COPD, so that indicates she's a smoker, which Tria said, yeah. And she also takes long-term corticosteroids for her COPD, and corticosteroids um, causes osteoporosis, can be a cause of osteoporosis as well. So just generally, for osteoporosis, some non-modifiable risk factors are age, so being over 60, being postmenopausal, having previous fractures as well, puts you at risk of osteoporosis. In terms of lifestyle, smoking increases the risk, drinking excess alcohol, having low vitamin D and calcium intake as well. In terms of medications to watch out for that can cause osteoporosis, so glucocorticoids, so the corticosteroids, so prednisolone, dexamethasone, can cause osteoporosis. Thyroid medications, so excess levothyroxine is also known to cause osteoporosis as well. Heparin and immunosuppressants, um, anticonvulsants such as phenytoin and carbamazepine, and also PPIs as well. So those who are on long-term PPIs, omeprazole, lansoprazole, that can also be a risk factor for osteoporosis as well. So the next question, how do you manage this patient? Just give a few seconds. Analgesia and physio, yeah, that's correct. Non-surgical, yeah. Vitamin D, yeah, that's correct. So if I go through the answers, so in terms of this patient, so um, in terms of conservative management, you'd want to give pain relief, so analgesia. You'd want to refer the patient for physiotherapy and bracing as well, and make sure that the patient that there's mobilization occurring. You'd also want to assess and treat the osteoporosis that the patient has, and you'd want to give vitamin D, calcium, and bisphosphonates for that. And you may want to consider surgery, so vertebroplasty and kyphoplasty, but this differs from case to case. Um, and surgery is typically indicated if there's a neurological deficit, if there's a burst fracture with retropulsion, and if there's instability as well of the spine. So the next case, so this is the final case. So a 78-year-old woman presents with a severe mid-back pain that has progressed over several weeks. Her pain is worse at night, not related to movement, as she now struggles to walk due to pain. She reports a urinary urgency over the past 48 hours. She has no history of trauma. Her past medical history includes hypertension and a breast lump that was removed many years ago. On examination, she has an antalgic gait, lower limb power slightly reduced, and she describes pain um the power of 4 out of 5, and um hyperreflexia, and she has reduced sensation below the mid-thoracic level. So what is the most likely diagnosis? Cauda. Yeah, metastatic spinal cord compression. Yeah, okay. Let's go through this then. So the most likely diagnosis is metastatic spinal cord compression. And what you should think when it comes to metastatic spinal cord compression is you should be thinking about it in anyone who's over 50 and who has back pain not caused by a mechanical or physical injury. They also have night pain, and you should always consider cancer until proven otherwise. Some other differentials that you should also consider, so a pathological vertebral fracture, osteomyelitis as well, or an epidural abscess. You should also consider primary spinal tumor as well, such as myeloma or lymphoma, and osteoporotic wedge fracture as well. So, so the next question, what investigations would you arrange for this patient? Let's give you a few seconds. MRI, yeah, yeah. So if I go on to the answer, so yeah, MRI, absolutely, it's the first line investigation. And metastatic cord compression is an emergency presentation, and you should do an MRI um, as soon as possible. And this is so you can confirm the spinal cord compression and detect if there's any masses that you can see. In terms of supportive tests as well, blood tests, you'd want to do your basics, FBC, CRP. You'd want to do calcium, so you can get hypercalcemia as well within metastatic cord compression or just malignancy in general. You'd want to do LFTs as well and a myeloma screen. So the next question, so what abnormalities can you identify on this patient's MRI? Just give it a few seconds. Yeah, wedge collapse met. Yeah, absolutely. So if we have a look at the vertebral bodies, we can see that there's abnormal signals that are coming that is appearing darker um, in multiple, yeah, urinary retention too, absolutely. So there's abnormal signal that's coming from the vertebral body, um, and this is very suggestive um, of malignancy of the spine. You also have wedge fractures, TRIA, um, stated as well. So there's a few wedge fractures as well. And there's also posterior involvement as well. And this is all highly suggestive of metastatic disease. You also have something called the winking owl sign. So this is seen on an AP view of the spine, and it's meant to look like an owl that is winking. So you can see the pedicles here, and then this is the spinous process, and it's meant to look like the beak of the owl, and these are meant to be the eyes. However, you can see on this level of the vertebrate that it appears that the pedicle is missing, and it's present on this side, and that gives the appearance of the owl winking, and this is highly suggestive of spinal metastasis. So, last question. So which primary cancers most commonly metastasize to the spine? Breast, prostate, yeah, that's correct, Ria. So if I just go through it, so the most common ones that metastasize to the spine: breast, lung, thyroid, kidneys, specifically renal cell carcinoma, and prostate cancers. And in elderly women, breast cancer is the most likely primary source. So if we go back to the history, she did have a breast lump that was removed many years ago. So this could be a cause of the metastatic spread in this patient. So one more question. So how is metastatic cord compression managed? Just give a few seconds. CT staging, yeah, that's correct. Yep, if I go through it. Surgical decompression, yeah. So in terms of the immediate management, you're correct, Natasha, with the CT staging actually. Um, and so it's an oncological emergency. So in terms of the immediate management, you'd want to give a high dose of IV dexamethasone, which helps reduce the edema within the spinal cord. You'd want to arrange an urgent MRI of the whole spine, and you'd want to contact neurosurgery as soon as possible, and you'd want to do an oncology referral as well. And in terms of definitive treatment, you'd want to do surgical decompression and stabilization of the spine, and you'd want to consider radiotherapy for tumor shrinkage, and you'd want to treat the underlying primary cancer if present. And that was the final question, guys. Thank you so much for listening. I hope this has been really useful for you, for everyone. And if you wouldn't mind, if you could scan this QR code and give any feedback you have, it would be really greatly appreciated.